Hello, good afternoon. Nothing like being the last speaker before the end of the day, right? I hope I can keep your attention here. So I'm going to talk about diversity in research. So this is really a microcosm of the problems that we face, whether it is in any kind of workforce. So when we do research, it impacts our basic every day-to-day lives. So the overview I'm going to talk about is what do we know about research? What do we do? And where do we really want to go? So I'm going to give you the takeaway point right in the beginning in case I lose you through this 10 minutes. Our approach is basically quite individualistic, and we know that very well. And as Mark Nivette said earlier, we work in silos, whether we are researchers, regardless of the science that we do, the research that we do, and whether it is the communities that we work in or deal with. So I'm at NIH, I'm at the National Cancer Institute, and I'm going to show to you that there's very, very few research grants that are funded to minority researchers, and they're underserved communities. And we have an issue defining underserved communities, and we can talk about that. For example, currently in my institute, we have very few grants that focus on interventions for health promotion or disease prevention that are sensitive, and I underline the word sensitive, and responsive, again underlined, to Native American communities. And more so, very, very few grants are accorded to Native American researchers. Now, this was published in Science, and it came out in 2011, and it was an analysis that Congress charged NIH to do on what they fund minority researchers based on race and ethnicity. If you see here, you will see Native American applicants have about 41 applications, and forget the percent, the number of awards given are 12. But I want to point out one thing to you. Most of these research grants are money set aside by Congress for Native American research. So there's an asterisk in that too. Asians, despite the fact that they're only 5% of the American population, do get a significant amount of the funding from NIH. African Americans get a very, very low level of funding from NIH. But also look at the percent of applications that really come in. They are at 1.4%. So what is happening to all the PhDs, MDs, EDDs, RN PhDs? Where are they? Why are they not coming to NIH for funding? Probably because we have not set a very good record of inviting them into NIH. So if you look at Hispanics, there's again a very small percent of Hispanics who come for applications to NIH. So this is something we're all quite familiar with. I'm sure you've seen this many times over. It's actually, I borrowed it from the Canadians, our neighbors up north. We say we do most prevention action is very individually based. So this individual is trying to roll this ball up the hill, trying to deal with environmental health hazards, lack of education, inadequate food and nutrition, unemployment, poor housing, and poverty all at one time. And we expect this individual to do it. And I'm so glad that Patrick Swift didn't read the rest of my resume, because I should have put a note at the bottom of it saying achieved individually and did it all by myself. And so when we talk about research at NIH and we talk about scope, design, and methods, a lot of you brought up these issues today. And I want to go over some of them very carefully, because I want to tell you that it is possible to change things. And change is slow, but it does change. Their community involvement, we thought that NIH would never, ever recognize community involvement in research. And now they say, well, if you're doing clinical trials, where's your community? So, okay, change can happen at the highest level. There have been community-based participatory research programs, and a lot of large programs at NIH require that there is community involvement. Now, the level of community involvement can be in question, and you might want to talk about community-based participatory research to community research to community kind of based research. Maybe epi work is that way, but you know, it's possible to have a gradient of factors there. We always in research say research is partitioned, where we have a limited scope, and we try to do a deficit model. So that's the whole problem with the definition of disparities. I am worse off than so and so, so give me some money. So I am doing so badly, then everybody give me more money. Why is it that we have such a deficit model? Why is it we cannot understand what do communities do correctly? That we want to understand that. And can we use those models in promoting health in other communities across the US and everywhere else? So we also have current challenges of scales and instruments. So we talk about culture. Culture doesn't mean the same thing to you and me. So people tell me that, oh, you originally came from India, but you speak English very well. Yeah, unfortunately I do. My constitution is written in English. And Supreme Court is argued in English. So am I acculturated to America? I don't know. So where do I fit on that scale? So acculturation, how do I answer that question? Am I really American? Am I not American? Am I Indian? Am I less Indian? So it's all very situational. So we need to calibrate our scales to what people think. If you ask a Native American, for example, I found out, how is your health? They'll never say it is bad. Because that is getting the bad spirits to tell you that you're bad, apparently. And I learned that the hard way. They always say they're doing well because you want the blessing to go on and do well. Am I right? Okay. So we need to calibrate our scales, understand what are we really measuring. Oh, it's the same with pain. There we go. So if you ask a person if they have pain and you say, no, okay, no medication for you, go home. What do we get out of that in public health? The other thing is, today we talked a little bit about RCT. RCT, I know that, it is, people think it is the model. It is the model for drugs. It is not the model for community. And it's even not the model for drugs. Because, I don't take only one drug at a time. I probably have BP issues, I have asthma issues, I have cancer issues, and all of them come together. So there is even a change in looking at clinical trials now to look at various diseases and various drugs at the same time. So quasi-designs work very well. What do you do when communities are small? How do you have controls? There are new methodologies. You can do stepped approach. You can do different kinds of approaches to RCT. So RCT is not something that you always need to think of when you think of NIH. So, when we talk about methods, when we do RCT, we always think quantitatively. Everything has to be put into a number. So it goes back to what Paula Braveman said earlier, right? That cartoon that she put up earlier today, you can average it out and we're all doing very well. So the thing of quantitative methods is you have to know what we're talking about. We go for the normal curve. Now, who's normal? I want to know. On every scale, I'm sure I'll come out abnormal somewhere. So there are this whole Bayesian research statistics where we take what is happening in the community. What is happening in the community to represent what is it we're talking about them. So there are new techniques out there. When we need to adopt them, we need to adapt them, and we need to use them. And there is also OBSSR, the Office of Behavioral and Social Science Research, did a whole seminar series on mixed methods. Not just that we do qualitative interviews just to do focus groups in the beginning, and then dump that group, and then go for our quantitative stuff. That's not the way to go. We need both methodologies to explain in a holistic manner what is happening in the community. So what we have data, we have tools, we have evidence, we have, of course, in this room, as we have seen, we have the commitment. And what I see of the posters there, we have some good resources to bring in the next generation, right? Thanks to HRSA. And which is also providing us with quite a bit of education and training. Maybe we need more in that area, but we probably will get there one day. But at the same time, we have to remember our continued emphasis of the individual has to stop. We talk about diagnosis of diseases, we talk about stage, and we talk about outcome. And then we talk about what is your level of physical activity? So I was in Alaska recently, and I was talking to the Yupik community, which uses a lot of seal oil in their cooking. That's what they have done apparently for centuries. And now talking to them about BMI, they're way off the scale. Now, if we didn't calibrate the BMI for the Alaskan population at all. We calibrated it for some other population and then called the Yupik population obese. So we really have a problem in how we do our work, don't we? So we recommend vigorous physical activity when these folks are really going out and doing whaling and fishing and hunting. But we tell them you need to do more vigorous physical activity. I just don't get what is the message that we're sending out in public health at the individual level. I had a research grantee who came to me and said, I want to do this intervention, health intervention, physical activity intervention among agricultural workers. These women need Pilates training. And I was like, really? Let's talk about this. After spending 10 hours out in the field in the sun, I'm going to come home and get on one of those machines. Give me a break here. Then at the individual level, we continue talking about rates of smoking, high-fat diet, alcohol use. So all at the individual level. We talk about the infection again in the individual level. Then we come and we say, poor access to care, you're not getting your screening done on time. You're not following up. What's wrong with you? Then we say, you live in high poverty. You don't have enough initiative to get out of that poverty. You're geographically isolated? Come on, move to a place where you can get better care. So when we talk about social determinants of health, we are shifting our thinking from the individual to the community, the family, the population. So these are the factors that affect us, that result in those differences. And if we focus on those, we can then focus on policy change. And then we can avoid those factors that create those injustices. So this is the social determinants of health definition as adopted in HP 2020. And the last group actually, which was formulated by Dr. Howard Koh, was the social determinants of health agenda, which I'm really honored to be a part of. So coming back to this wonderful poor guy pushing the ball up the hill. So as I said, most of our work is individually oriented and we lack attention in the systemic level. So I would come to the research arena and I would say, I'm a medical sociologist. I work on type 2 diabetes. I have great quantitative skills. I want to do health literacy and social justice, right? And I usually would go find a community that likes all those things, right? Who cares about the attention there where it just says, is it relevant? Is it holistic? Are you dealing with issues of poverty, housing, prevention, environment, community, neighborhood? Until and unless we can take an attention that brings all these factors together, we're never going to get at disparities or achieve equity. So I'm going to offer you some advice unasked for, of course, as always, at the end of the day so that you can go home feeling really good. But I hope these are ideas that you can use to apply to NIH. So I have ABC, but after having given ABC, I'll start at the bottom. So I hope in conducting research, we can do comprehensive studies that deal with cross-cutting factors that are holistic. Most of the factors that affect, say, cardiovascular disease, cancer, type 2 diabetes, the prevention factors are quite similar. So I hope we can come up with very holistic kind of projects. B, build partnerships. Don't work in silos. Bring different researchers together. Get advice from everyone possibly before you go out into the field. From everybody in the community to all kinds of research agendas. Until we do that, we're not going to move the health forward. It's not that today I can go to the doctor for my left eye and tomorrow for my right kidney. It would be great if I can go for my left eye and my right kidney at the same time. Come on. Let's not break ourselves up. Apply design and methods that are relevant to research question and the community. So adopt a holistic model. Actually, these are things that I learned the hard way. And I hope we don't continue teaching it to the next generation in a hard way also. It took us, we have, for example, currently at NIH, a program announcement for Native Americans and Alaskan Natives and Native Hawaiians. We specifically stated in that we did not want researchers to think of only one outcome. We wanted them to think about multiple outcomes. So we have partners such as the National Cancer Institute, Heart, Lung, and Blood, Nursing Institute, Environmental Institute, Drug Abuse, Alcoholism, and Alcohol Abuse. We wanted them to think about it in the most broad, holistic manner. Let us decide and let us worry about how it gets funded. You do what is so relevant to the community and do the work that is most important for them. So I will end with two quotes. The I illness is isolation, and the crucial letters in wellness are we. And another one, nothing great was ever achieved without enthusiasm. And today I've realized that this is a very, very enthusiastic group. So thank you, Shanita, for inviting me.
Right.